about finance and how it's going to happen and what the timings are, sort of the whole thing in there. The timings in terms of that GP centre coordinated care, it's got to happen in this coming year. That was set and agreed to
by the end of 2015. Sorry for jumping in.
Yes. That's the plan, and that's that was mandated by the government, agreed to by the CCGs. Essentially, that's the timescale. These are things. This is how the health services work.
Can I come back on that, because you've instanced a number of times, quite rightly, about the central place of the CCG. But I do know I went to the King's Fund AGM about 2 weeks ago, and they were looking at financial planning and saying that a range of bodies did not have financial plans because the CCGs had not done their work. And one of those is the one we're sitting in now, because their AGM should have happened in early March, and it was sliding by till the day before when it was cancelled, and it's now to be sometime in the summer. Well, that goes on really till September, and that's a long flow of something really is to happen in 15. So it sounds very unlikely.
And that's where I would just hold my hands up and say it's not something we can influence at all. I take the points, and I think it's fair to say everybody's aware of how challenging, if that's a fair word, this is. It's not something we're trying to be involved with, because there are many things that need to be local. They need to be Hammersmith and Fulham level. There are some other things, like things I mentioned before, that make sense to do at a North West London level, and some other things that make sense to do at a national level. I'll come back to the bit that we are doing specifically, and I'll sort of elide the whole section about where the money is going to come from for the piece of work that we're not involved with, if you'll forgive me. Somebody else might be better placed to sort of answer that. I'm talking about the early adopters. So let's go to slide 11, which answers your question specifically. What we're talking about when we say early adopters are ones that are going to do what we talked about before, but some more. So what they're going to do is start worrying about people with long-term conditions, so say diabetes. How do we make sure that they get the kind of services that patients are always asking for? So it's not that you have to go up to the hospital when things get too bad, and it's not that you have to make all the appointments yourself, but in fact they all come around you. So you get care at home, you get appropriate referral to foot clinic, whatever it might be about your particular thing. That there is communication between all the people who are involved. If there's social care involved, they're talking to healthcare and so on. All the things that we have talked about and everybody knows about that sort of constitute integrated care. What we asked is that some areas try to go a bit further with that. And the reason that they need to go a bit further with that is because we don't know what the cost implications will be. So there's a belief that if you got some of those things right, so you didn't have people being cared for inappropriately or being allowed to get too ill before you do anything about it, that you might actually save some money. And it's possible that's true. It's possible it's not true, but we believe it's true. The early adopters are going to test that out. So there are a number of things they have to have done to become an early adopter, and one of them is that they're going to really carefully monitor what happens, whether it costs more, where the resource come from, how that's going to be done. So one thing they might look at is where the GPs have been the centre of the care. Is it actually the GP, or is it a nurse they appoint specifically to be that care centre? They're the kinds of questions that people are looking at. Where they are is captured in slide 13. Slide 11 shows you who wanted to do it. You can see there's a big number there of people who have areas that were interested in doing it. And an area in this case had to have included one of the hospital providers, a CCG, a local authority, third sector, and patients. That's how it's supposed to have been. So nobody was allowed to go beyond the first stage if they hadn't got all of those things involved. Otherwise it wouldn't be whole systems.
Clarification, because it sounds good. You mentioned 4 bodies there, including doctors' groups.
Yes.
Does that mean that any one of them, were they to lag behind, have the ability to hold all the others back? For example, were a local council not to provide money, or GP services not to opt in? That would stymie things.
Well, obviously that could happen, but what we've tried to do is make sure that the ones that have moved, so from the 25 that you see on page 11 down to the 11 that I mentioned, actually, is it 11 on here now? Keeps changing these numbers, it's 11. On page 13, yes. Are the ones that seem most likely. So they seem to have proper sign-up. You can never know entirely, but they've all been signed up to by their chief executives, for example, who said, we commit to being part of this process. So we've done what we can before any cash is put on the table to make sure that it's a genuine. And you know, there is a bit of push from things like the Care Act and so on. There are some reasons why local authorities and local healthcare providers need to do this. So we've come to this list of 11, which are borough-based, plus one or two that are looking across sort of big issues, like you see cancer there. There's one that cuts across several about severe and enduring mental illness issues. So some things that don't make sense to deliver in just one area. What's provided centrally is outlined on slide 14, page 14 here. And this is all stuff that we've done in order to make sure we gather that information that you so rightly said we need to gather. So the project manager, in a way, the job is to make sure that it keeps moving, so it doesn't just fall off and stop doing anything. Also that evidence is gathered, so we know whether it's costing more, less, is more efficient, is better for patients or not, those kinds of questions. And they'll be using our toolkit and all those other things that we've developed, of course. And you'll see there's a little slide there that sort of answers what I said, which is that support will only be made available. In fact, they'll only be called early adopters if they fulfil a set of criteria. There's more than this, but essentially it's that, you know, we're convinced that the commitment's real. Slide 15, my penultimate slide, is just what we expect to happen and how quickly. And it's probably worth mentioning, given what questions have been asked, that towards the end of April, it's actually probably going to be the second week in May, there'll be what we've called here a checkpoint. What we're going to have is some external people from outside of North West London, national figures, if you like, who will look at each and every one of these. We'll have a presentation where the local areas are going to come and say, this is what we're doing, and they can have sort of a, you know, well, a scorecard, a report card, if you like. So it gives a little bit of extra impetus to try and make sure people really push on that. My final slide, and I'm happy to answer questions, but I do realise I've sort of taken up quite a lot of your meetings now. I just wanted to finish by emphasising that the lay partners I described at the beginning, the bit of work that Alice and I work on, are going to be in all of this. So the early adopter projects, some of them had their first meeting last week, some are having their first meetings next week. At each and every one of those, we've had lay partners at the very beginning of the co-design process. The co-design principles are something that is part of the list of things they have to sign up to. And there's only two, Alice and I, but I'm fairly happy that all of the project managers and leaders have got the message that this is how we want to do things. And it's why I mentioned a couple of times about how exciting it seems, because actually we are able to get that message across to the people who, you know, the technicians, if you like, who are doing the project leading, and hopefully across to the clinicians and the social work and everybody else who's involved in the projects. That's probably all I have to say on the slide, but I'm happy to talk as much as you like about anything else.